I want to welcome everyone to the RDAR Center seminar. The RDAR Center stands for the Rural Drug Addiction Research Center, which is a COBRA here at NIH-funded COBRA here at Nebraska, if you're not familiar with the RDAR Center. I am very excited to introduce our speakers today. My name is Devin Crawford. I am the Center Administrator for the RDAR Center. So we're going to have two speakers. We're going to do a talk, some Q&A, and a talk, some Q&A, and then be able to do general conversation at the end as well. So if you have questions for each speaker following their discussion, we will take those in the chat, and Callie and I will help make sure that we're moderating those questions as they come in as well. And then at the very end, we will also have time for questions in case something comes up or connections between the talk or anything like that. So we'll get started. Our first speaker today is Dr. Brendan Jacka. He is an investigator in epidemiology at the People, Place, and Health Collective at Brown University School of Public Health. He received his PhD in molecular epidemiology from the Kirby Institute at UNSW Australia in 2015 and undertook postdoctoral training at the National Drug and Alcohol Research Center. He was also at the University of Montreal and Brown University School of Public Health. Dr. Jacka's research interests broadly encompass drug-related outcomes, including the intersection of harm reduction, overdose prevention and treatment, and trauma-related research. Dr. Jacka is also a pilot project awardee for the COBRA on opioids and overdose. So I am very excited for your talk. Thank you so much. I'm going to go ahead and go off camera so everyone can focus on you and your presentation, and then we'll come back for Q&A.
Fantastic. Thank you, Devin. Thank you so much for that introduction. I'm just going to share the screen. Mode. Thank you so much. And so, as Devin mentioned, this presentation relates to the COBRA pilot project that I received this last year. So it was awarded in the end of 2020, and the study has occurred this 2021. So tomorrow will be the last day that we interview participants, and then we will have to do some scoring of outcomes. But what I'm presenting today is some preliminary results. So about 70 of our target 100 individuals that I'll be showing you the results of. So I have no conflicts of interest to disclose. So I don't want to labor this point, but I think we're all aware of the massive number of people that have passed away in 2020, fatal overdoses. We also might assume that 2 or 3 or 4 more overdose events happened that were not fatal. So we could be thinking of, upwards of 500,000 overdose events occurred in 2020. And we know that in the last few years, the public health response has been to ask peers to address the overdose. So we're saying we're educating them on how to identify an overdose. We're asking them to carry naloxone at all time, and we're suggesting to never use alone. So we're saying asking another person to be in that space when an overdose may potentially happen. And so these are good public health interventions to support the person who experiences an overdose. And the work that I'll be presenting today is saying what happens to the individual that respond to the overdose. As I mentioned here, the idea that we're taking away essentially the workload from professionals and providing it to asking non-professionals to take this work on. This has particularly been exaggerated or expanded as illicitly manufactured fentanyl moves into press pills and stimulants away from typical heroin. I just want to stop or pause here for a moment and say that we understand from trauma work in other fields that exposure to trauma, which is obviously kind of like necessary for post-traumatic disorder, may develop in individuals in different rates depending on the type of trauma that they're exposed to. For example, natural disasters may be less distressing than an individual kind of targeted experience. So we know that there's not all people exposed to a trauma will develop PTSD, but varies whether for a person's trauma experience. We also know, and there's been written recently in reasonably qualitative experiences, that first responders, professional and non-professional, are reporting high burnout and compassion fatigue related to the overdose crisis. You know, for example, talking about reviving or supporting a person who's experienced an overdose multiple times and saying it doesn't feel like it's helping. So that is kind of coming out in the literature in the last few years, but little is known about what is happening to the people that we're asking in the community to do this response. So that was what prompted this research. Oh. And so the work here, the pilot study, the 12-month project, was really to demonstrate that we could do this recruitment, that we could take or identify people in the community and recruit them for a study survey. So it was a one-visit study. It builds on some work that our team in Rhode Island does, led by Dr. Brendan Marshall, which is recruiting people who use drugs at risk for overdose. So using targeted advertising through social media, online recruitment, working with community-based organisers. So we wanted to demonstrate or assess feasibility of recruiting people who use drugs, but also the next layer out of people affected by overdose, such as their family and friends or people in recovery that had used drugs in the past that still live with this exposure to trauma. And we wanted to kind of like get a snapshot of what is happening in the community. The next step from this was, among the people that we recruited and interviewed, we wanted to understand the prevalence and then also the characteristics of PTSD in this group. I should acknowledge that we're talking about particular overdose events, but in aggregate, but it may be distressing for some people that have experience with this or are otherwise affected. So apologies if this causes any distress, this conversation. So we had two quite simple research aims, and the goal was to recruit 100 individuals. The cross-sectional study originally was planned to be a kind of participant-administered questionnaire through web-based and with some collaboration with a clinical psychologist, Dr. Nicole Weiss at URI. We modified the study to be a clinician-administered interview. So participants that screened eligible would have a 1.5 hour, 1 hour to 1.5 hour interview with a master's level clinician under the guidance of Dr. Weiss. And as part of that, we administered what's called the CAPS, the Clinician Administered PTSD Scale for DSM-5. So this was it is essentially an extension of screening tools used to identify people with PTSD and adds on the clinician's expertise. So we kind of say, are their responses actually related to it with our clinical experience, or is it kind of like unrelated? So as I mentioned, the population we were targeting was quite broad. It was essentially adults that had English proficiency that were not professional responders or emergency personnel. And this was because we think they have unique circumstances that would be best served with a different study. And we say responding as being involved somehow. So calling for medical support or administering naloxone or doing CPR. So a step more than just being in the same space at the same time. I just wanted to briefly say that we did assess other trauma experiences that individuals had. And we had one question at the end of the trauma history saying, did the participants consider the overdose as the most distressing event? If they said no, then they, at the end of the study, they would do a small screening tool for that event. So what may be like the globally most distressing event. But all individuals completed the CAP study on the index overdose event. So the event that they considered most distressing, the overdose event they considered most distressing. This is slightly different than the other ways the CAPS is implemented. As I mentioned, the Results are still ongoing, so we have still to do clinical review of the last 30 or so participants. So I'll show you some descriptive statistics of the first 70 with PTSD results, and also some simple comparisons against some of the factors that we thought might be important. So the majority of individuals, the median age was 33 years, which kind of matches to a degree people who use drugs. So we're capturing a range of individuals. About half were male. We did have a reasonably high proportion that were transgender, and about half were non-white, possibly reflecting the initial recruitment that was Rhode Island focused. So our study was originally based on physical advertising in Rhode Island, and then we expanded to Facebook and Instagram advertising around the country. And so housing instability was also quite high, potentially related to some of the community organizations that we work with that work with individuals with unstable housing. Almost all participants had completed school, and about half were employed at the time of the interview. So for the overdose incident event, the majority were in a private location, which fits in with the Rhode Island information. I will need to look a bit further to see individuals not in Rhode Island, but most overdose events were not happening in public. And then we did ask information about public events occurring, for example, in a train station versus not in such a public space. Most individuals said that the relationship to the person or persons who experienced the overdose, the index event, was close, and about nearly half had said that they had also used drugs at the same time, and a proportion of those said that they helped obtain drugs, such as providing money or going to get the drugs. In terms of the response, about half of people administered naloxone, and 2/3 called for medical assistance. And other people provided other responses, such as like chest nuggies or putting ice in their face or down their pants, for example. So a range of different responses provided, but some individuals provided like all three and others just did one of the three. The majority of people who experienced the overdose were transferred to hospital, and police and EMS arrived for most people. So it wasn't just all on the shoulders of the responders. In the sample, we found about 1/4 of individuals had symptoms of clinical PTSD. So they met the criteria for responses such as nightmares, flashbacks, avoidance, for example. So this is a relatively high proportion, which is similar to individuals that experience sexual or physical violence. And this relates specifically to the overdose event. So just to clarify that this is not general PTSD symptoms, but 27% of participants had PTSD symptoms related to their most distressing overdose response. We also found a high occurrence of anxiety and depression among the PTSD group, so statistically higher prevalence of anxiety and depression. And we also asked individuals if their substance use changed in the 6 months and the whole time since their index event. About a quarter of participants said that in the 6 months after their most distressing event, they reduced substance use. An additional 15% said that they increased substance use. And so that left about half of people that didn't change their substance use. We also asked substance use over the longer time, and a high proportion, about 1 in 3, said that they've reduced the substance use. So to us, this is kind of an area of focus going forward, is to what degree does responding to overdoses impact a person's subsequent substance use? And finally, just some quick overview of results. we wanted to demonstrate to look into factors that were associated with this clinical PTSD. And we've been very conservative here, adjusting for multiple comparisons. So if we had tested many variables, that by statistic chance, we would have identified a few. So we've decided to pick only the ones that are most significantly related to clinical PTSD. And in this sense, none of the individual factors that we looked at were associated with PTSD. None of the environmental factors, so none of the overdose event factors were associated with PTSD. And only 3 of the psychological factors. So as I mentioned, severe anxiety, moderate to severe anxiety, moderate severe depression were associated, as was emotional dysregulation. So participants that had more difficulty managing their emotions were more likely to have clinical PTSD. We had thoughts that social isolation or self-efficacy of coping might be related, but they were not associated. So just to finish up, we demonstrated capacity to recruit these individuals. In about 7 months, we recruited 100 individuals, predominantly in New England, but across the US. We targeted individuals that may previously been considered hard to reach, but I like to reframe as hardly reached as a sign that as researchers, we need to do better at accessing these communities rather than shifting blame to them not participating. So we are proud to have been able to reach these individuals and would like to continue research in this community. We've also seen that the overdose responding events are heterogeneous, so they occur in different locations. They're not, primarily in one spot. What people do during those events are different. One individual may provide all responses, one individual may just call for help and then stop. So at the moment, it seems that these differences are not impacting people's PTSD. So we really want to identify maybe what other factors might be involved. And we're also seeing a really high burden. So this is individuals that would be suitable for treatment related to this PTSD. And one last point is that I really wanted to say is that by essentially showing an absence of factors means that we can't kind of just target our interventions so much to kind of people in the community. So our responses are going to have to be kind of heterogeneous, responding to the needs of the community, and I think very novel, and it's going to require a lot of work from clinicians and researchers to address this unmet need in the community. So I just wanted to acknowledge and thank funding from the COBRA on Opioids and Overdose in Providence, including the Special Populations Core, the Administrative Core, and the Data and Research Methods Core. The People, Place and Health Collective have been fantastic and very supportive of my work. Among those, Dr. Brendan Marshall, and also the co-investigators, Dr. Nicole Weiss and Dr. Elizabeth Samuels, and absolutely the research personnel and the participants and the community partners have been fantastic. And that's my presentation. Thank you.
Awesome. Thank you so much. We really appreciate it. We're doing the virtual clapping since we are in the in the virtual setting. I am very excited to introduce our second speaker, Dr. Patience Moyo, who's a faculty within the Center of Gerontology and Healthcare Research at the Brown University School of Public Health. She's trained in pharmacological health service research and has expertise in the use of large administrative data to conduct epidemiological and policy analysis. Her current research focuses on health service use, quality of care, and outcomes in management of chronic pain and opioid addiction. Dr. Moyo was previously awarded a pilot project from the COBRA in Opioids and Overdose, and is now a recipient of the Project Lead Award from the COBRA in Addiction and Disease Risk Exacerbation, the CADRE, which we are also working closely with as well this year. And I'm very excited to have been building those relationships with a new partner, COBRA, this past year. So thank you so much. I will go off screen again and be here to answer any questions that anyone has.
Thank you for that introduction and for inviting me to share my work with this group this afternoon. As was said, my name is Patience Moyo, and I will be talking today about the subject of opioid prescribing and non-pharmacologic treatment use for chronic pain in adults who have co-occurring opioid use disorder. This is a brief roadmap in terms of what I'm going to cover today. I'll talk a little bit about the funding, and then I'll go into the study itself, and we'll have plenty of time for questions and comments at the end. This study that I'm presenting today was funded by the cadre, which is led by Peter Monti, Jennifer Tidy, and Jazz Aluelia. So I wanted to make sure I acknowledged them and that funding before I got started. Within the cadre, I am leading Project 2. I'm the PI, also known as project leader under Project 2. Within this project, I am lucky enough to work with a tremendous team, including several mentors who I also think of as co-investigators in this work because they bring tremendous expertise. Brendan Marshall, who's my primary mentor in this work. Other mentors are Teresa Scheiman and Amal Trivedi. All of them are at the Brown University School of Public Health. I also work with Dr. Jessica Merlin. She's at the University of Pittsburgh. She's a consultant on this project. Cara Roffe is an MPH candidate who is working with me as a research assistant. And Miriam George is a data analyst that's working with me in this project. And to start, I'm going to talk a little bit about chronic pain. And some of this is probably material that many of you know, but it provides good context for what I'm going to be talking about in relation to the work that we're doing in this study. In 2016, it was estimated that roughly 20% of US adults had chronic pain. And this prevalence of chronic pain increases with increasing age. And also, in treating chronic pain, many of you may realize that over the past several years, there's been an emphasis on reducing opioid prescribing for chronic pain, partly because there's inadequate support for opioid safety and effectiveness of opioids when they're used long-term. There are studies, in fact, there's a systematic review that found that approximately 21 to 29% of individuals who are prescribed opioids for chronic pain misuse them, and about 8 to 12% of people using opioids for chronic pain develop opioid use disorder. And this is not even getting at the overdose related harm that's experienced. And so there are a lot of safety concerns around opioid prescribing to manage chronic pain. And I am particularly interested in my work in thinking about the overlap of chronic pain and opioid use disorder. And I found the statistic interesting that approximately 50% of individuals who have OUD also have chronic pain. And so in this context, I'm very interested in thinking about among these individuals who have these overlapping conditions, how is chronic pain managed? And there are potentially, some challenges that can arise in terms of prescribing opioids to someone who has an opioid addiction. And so I'm interested in how that then affects the treatment that the individual gets for their pain. There have also been various clinical guidelines that have been put forward in the past several years to improve the quality of pain management and promote safer opioid prescribing, particularly in the context of non-cancer chronic pain. And the CDC opioid guideline is one example. There are several other guidelines and recommendations, some of which are advanced by various medical societies that are out there. But in thinking about the CDC opioid guideline that was put forward in 2016, there are a variety of recommendations that are included in that guideline. And here I include a subset. And these guidelines were developed with non-cancer chronic pain in mind, and really trying to promote safer utilization of opioids if opioids are used to treat chronic pain. But they also call for the use of non-opioid medications and non-pharmacologic treatments before initiating opioid therapy. While these guidelines really target chronic pain, they also offer some recommendations that are specific to navigating opioid prescribing among individuals who have OUD or who are at high risk for opioid overdose. For example, they recommend co-prescribing naloxone to individuals who are at high risk of overdose, but also making sure that individuals who have OUD receive treatment, which is usually medication combined with behavioral therapies. Despite the emergence of these guidelines, there's still a lot that we don't know in terms of utilization of non-pharmacologic treatments in particular. They're recommended in these guidelines as first-line therapy for treating chronic pain, but there are a lot of gaps in terms of what are the trajectories of use for these non-pharmacologic pain strategies, and what strategies are people using, and what's the variation in the uptake of these different strategies based on individual provider or geographic factors. And at the same time, there are gaps in terms of the extent to which there is guideline concordant chronic pain management in key subgroups, including people who have OUD and racial and ethnic minorities. There's a really well-documented literature to date that talks about disparities in pain management and how historically minorities have been less likely to have been prescribed opioids. And so given that background, I'm curious to find out whether these minorities will then be utilizing non-pharmacologic treatments more or not, and thinking about how the guidelines have impacted these particular groups. There are two main questions that this project seeks to answer. One has to do with understanding the prevalence of the use of opioid and non-pharmacologic pain treatments among people with co-occurring OUD overall, and also within subgroups of racial and ethnic minorities. And also in a second question, I want to evaluate whether the implementation of the CDC guidelines has worsened or attenuated any disparities in pain treatment that may exist. I'm interested in thinking about this both from the opioid prescribing perspective, but also from the non-pharmacologic treatment use side. This study will use secondary data. We're using Medicare claims from a 20% national sample. We have access to data from 2011 to 2019 for the study, and a variety of different files, including inpatient and outpatient data, pharmacy data from Medicare Part D. And then we'll also be combining that with other types of publicly available data sets to get some information about community characteristics and the availability of providers in different communities. This is preliminary data to give a sense of the size of the sample that we are working with in the Medicare claims data. This is a snapshot based on 1 year of data. This is 2016. And what I wanted to share, in case there are people who are not familiar with Medicare, is that within the 20% sample, focusing on individuals who have Medicare fee-for-service coverage. This is not individuals who have managed care coverage through Medicare Advantage, but fee-for-service enrollees. We find that in this 1 year, there are just over 6.5 million individuals in the data for this 1 year, and 84% of those individuals are in the older adult demographic, which is defined as being at least 65 years of age. But we do have a sample that's under 65, just over 1 million individuals. The demographics of the Medicare population do heavily skew toward non-Hispanic whites, who represent 80% of our data. But when you look at the younger age group in the data set, that has a bit more racial and ethnic diversity relative to the age over 65 subgroup. And then when we searched pain conditions, I highlighted a few different pain conditions here: osteoarthritis, low back pain, chronic pain based on ICD-10 codes for chronic pain syndrome or chronic pain not elsewhere classified, neck pain, migraines, and then I have a composite pain measure that captures any of these above measures. And we do see that pain is very common among Medicare beneficiaries, including those under 65, many of whom are actually eligible for Medicare because of disability-related reasons if they're under 65, which makes sense that they have a lot of pain conditions. And then when we look at individuals who have a diagnosis for a diagnosis claim for OUD in this one particular year, overall that's 1.4% and 5.2% among the under 65 population and 0.7% in the over 65. And then when you look at if someone has any of these pain conditions and OUD, what numbers do you have? And so at this point, we really end up with a smaller subset, given that we start with about 6.6 million. But when we look at the overlap of these conditions, we have about 75,000 individuals who have this. And so this is preliminary data, and we're continuing to develop our cohorts and refine our sample size numbers. But I wanted to give people a sense of what we have. The outcomes that we're exploring really relate to the type of chronic pain treatment that's provided based on opioid prescriptions. We're focusing on any prescription of opioids, but also looking at opioid dosages in terms of the daily morphine milligram equivalent dosages, and looking at the overlap between opioid and benzodiazepine prescriptions, which are known to increase overdose risk. And then on the non-pharmacologic treatments, Medicare only covers so many non-pharmacologic treatments, and even then there are some restrictions in terms of the type of pain condition for which these treatments would be covered by Medicare. In general, though, physical therapy is more comprehensively covered than any other non-pharmacologic treatment in Medicare, and chiropractic care follows as well. In 2020, Medicare started covering for acupuncture, but that's beyond the data that we have for this study. And so we'll be able to capture any use of these services, but also the intensity in terms of the number of visits that individuals had for receiving these treatments. There are two specific aims in this project. In the first one, we are interested in identifying the longitudinal trajectories and factors that are associated with non-pharmacologic treatment use among individuals with new episodes of chronic pain. And in this aim, I hypothesize that we will see different patterns of initiation and persistence with non-pharmacologic pain treatment use. among individuals who are racial and ethnic minorities, and also among individuals with OUD. At this time, I'm not entirely sure 100% which direction these patterns will go, because as I mentioned before, minorities have disproportionately been less likely to be prescribed opioids. And so there's a possibility that we will observe that they were more likely to be initiating treatment, non-pharmacologic treatments. But I do suspect that there are disparities in initiation and persistence with these treatments, whether you're looking at across racial and ethnic minorities or across people with or without OUD. And then in a sub-analysis, we will be looking at modifiable factors that can address disparities in terms of co-prescribing naloxone, which we can capture from Part D data. And we have data that provides information about the specialty of the individual providing care. And so I do think that individuals who are receiving care from pain management specialists as well as addiction specialists are individuals where that's potentially a modifiable factor that can help reduce disparities, as well as among people with OUD, making sure that they receive treatment for OUD might actually help reduce disparities in the treatment of pain. Then in the second aim, I'm particularly interested in understanding how the CDC guidelines affected potential disparities in the treatment of pain. And so this will be a time series analysis that is going to explore the patterns in pharmacologic treatment use, particularly opioid treatment use before and after the guidelines, and also the treatments received for physical therapy and chiropractic care before and after the guidelines, and looking at this overall and across race and ethnicity, and also among individuals with and without OUD, to figure out whether following the implementation of the guidelines, we see a widening or a narrowing in terms of the disparities in receipt of these different kinds of treatments. So next, I'm going to talk a little bit about what we are doing now in this project, including doing an evidence synthesis that is really helping us to map the existing literature on non-pharmacologic treatment use in managing chronic pain among people who have disabilities and among older adults who are enrolled in Medicare. We did consider expanding this to the entire general population, but we are very interested in the Medicare population because of its size. It's growing very quickly, and I think we will be able to really focus this well on Medicare and Medicare policy by narrowing it down to Medicare for now. And then the questions that we hope to address through this evidence synthesis, the scoping review, relate to the uptake of non-pharmacologic treatment use, whether that has changed over time with the evolution of the opioid epidemic and reductions in opioid prescribing, which we know there have been reductions in opioid prescribing since 2011. And we're also interested in exploring whether non-pharmacologic pain treatments are being used predominantly as alternatives or as complements to medications, which can include opioids, but potentially other non-opioid medications as well. And exploring what the characteristics of non-pharmacologic pain treatment use are in terms of type, duration, frequency, and setting. And so for this review, we are not restricting our non-pharmacologic treatments of interest to the ones that are covered by Medicare, but we're really interested in understanding the broad scope of non-pharmacologic treatments that are potentially being used by this population. And we want to find out whether the literature addresses key subgroups that are of interest, such as people who have specific types of pain, or racial and ethnic minorities, or individuals who have substance use disorders. And then lastly, we're interested in exploring barriers and facilitators to non-pharmacologic treatment use for pain. This is a preliminary literature search that Clara Ruffey conducted last month. We still have a lot of work to do, but we've identified our search terms. And this was a query that we conducted in PubMed. And it's essentially, I'm presenting this to give you a sense of the number of articles that are being identified preliminarily by searching the pain terms. That's the first concept here, S1, almost 800,000 articles. And then S2 is focused on pain treatments. This is truncated. There's a long list, but about 1.3 million articles there. And then S3 is looking at Medicare in particular, 79,000 or so. And then when we combine these concepts, which is really what we're interested in this study, there are about almost 300 studies that are identified before screening. And so this is to just give a sense that we will have some studies to work with. It won't be a lot, but we definitely have a good number of studies to screen and analyze to answer our questions. Then at the same time, we are working on creating our analytical files using the Medicare claims data that we have to identify individuals with back pain and opioid use disorder. So for this study, our first aim, we decided to narrow it down to low back pain in particular, chronic low back pain, just because when we assess the literature, we find that this is where the evidence is strongest in terms of the potential utility for using non-pharmacologic treatments for pain. And so we're really going to focus on a cohort of individuals who have chronic low back pain for this study. So we're creating those files and identifying the pain treatments. We have national drug codes that we're using, and we also have procedure codes that we're using to identify non-pharmacologic treatment use. And so that's all in the works. And then lastly, this is a slide that I wanted to share to indicate that we are very early in the life cycle of this project, which was funded earlier this year. Right now, we are essentially in year one, and it's October right now, and we are still working on creating our analytical files. And so as time goes, we will begin to have results, and I hope to come back later on and share with you all what we've learned in our work. So that's the end of my presentation. Thank you so much for your attention.